Imagine sitting on the exam table at a doctor's clinic. You have this relentlessly runny nose.
Right, just a super common, everyday annoyance.
Exactly. But the doctor walks in, looks at you,
Yeah.
and instead of asking about your allergies or like, what kind of pollen is in the air, they ask this seemingly bizarre question. They say, can you sniff it back?
Which, sounds almost intrusive or just weirdly specific.
Yeah, it really does. And if you say no, like if you physically cannot sniff that drip back into your nasal cavity, the doctor isn't just writing a prescription for antihistamines.
No, definitely not. They're internally sounding the alarm for a fresh install. Because you might actually be leaking cerebrospinal fluid straight from your brain.
Wow. And today's deep dive is all about uncovering those exact hidden tripwires. We've got this massive stack of pages from a clinical methods manual, specifically an ear, nose, and throat manual that's used to train medical professionals.
Right, it is the literal step-by-step guidebook.
Yeah. And our mission today is to decode the hidden choreography and like the underlying algorithm running in the background of a doctor's visit. We want to show you exactly why your doctor asks such bizarrely specific questions and performs tests that seem entirely unrelated to your symptoms.
Because what you experience as, a casual 15-minute conversation and a quick physical check, it's actually a rigorously structured data-gathering operation.
Right, it's not just a chat.
Exactly. The manual we are looking at essentially programs the medical student to stop making assumptions, and start gathering actual functional evidence.
Okay, let's unpack this. I want to jump right into the data gathering part. Specifically, how a doctor builds a suspect list before they ever even reach for a tool. The manual dedicates pages upon pages just to patient history.
Oh yeah, the level of granularity is intense.
It really is. Like if you complain of ear discharge, the manual demands the doc establish the duration of the specific site, the color, whether it's yellowish, greenish, brownish, and the consistency.
Because the consistency actually dictates the underlying pathology. A doctor needs to know if the fluid is watery, which, might indicate a simple acute infection.
Right, like a standard earache.
Exactly. Or if it's tenacious, meaning thick and sticky, well, that could point to a chronic issue involving the deeper mucous membranes.
My absolute favorite detail in this initial screening is the instruction to ask the patient if the discharge, quote, wets the pillow at night.
Yes, it is such a great diagnostic question.
It's just such a visceral, highly practical way to gauge the volume of fluid, right?
Yeah.
Without asking a patient to somehow estimate in milliliters. But I do have to push back on this idealized scenario a little bit.
Okay, go for it.
Well, I've been to a busy clinic. The doctor usually gets me in and out in about 7 minutes. Are they really running through this exhaustive checklist for every single earache? Or is this manual just like a fantasy of how medicine should work?
That is a really fair point. It is definitely an idealized training baseline. And you're touching on a major tension in modern medicine here.
Right, the reality versus the textbook.
Yeah, because in a real-world clinic with high patient turnover, doctors rely heavily on pattern recognition. They skip steps, they compress the algorithm.
Which makes sense for time.
It does, but that compression is exactly where misdiagnoses happen. This manual forces the student to recognize that skipping a question about consistency or color might mean missing the difference between a minor ear canal irritation and like a bone-destroying infection.
Wow.
Yeah, the rigid script is there to prevent complacency before they ever develop their shortcuts.
That becomes incredibly apparent when the manual tackles hearing loss. The doctor is instructed to clarify if the hearing loss is fluctuating or constant.
Which is a huge distinction.
Right, because to a patient, a bad ear is just a bad ear. But biologically, the mechanism causing a fluctuating loss is entirely different from a constant loss.
Completely different.
If your hearing gets better and worse over time, that points to a mechanical blockage, like fluid building up behind the eardrum, draining away and then building up again.
Whereas a constant progressive decline in hearing suggests a sensorineural problem.
Meaning the nerves themselves.
Right. The delicate nerve pathways transmitting sound to the brain are degrading. And nerves generally do not fluctuate in their performance day to day. Once they are damaged, the deficit is constant.
So they're sorting out mechanics versus neurology just with that one question. And the manual then adds another layer to that, instructing the doctor to ask, is the problem hearing the sounds or understanding the words?
I love that distinction.
Think about the physics and neurology of that. You can hear a truck driving by or a dog barking perfectly fine, but human speech sounds like garbled nonsense.
Yeah, which tells the doctor so much.
The mechanical parts of your ear, the eardrum, the little bones, they are vibrating and doing their job to capture the acoustic energy perfectly well, but the neurological processing center is failing to decode that energy into language.
By establishing that one detail, the doctor instantly stops looking at the physical ear canal. They shift their entire focus to the auditory cortex and the nerve pathways.
That's wild.
It is. They are literally mapping your nervous system based entirely on your vocabulary and comprehension.
Which brings us back to the runny nose scenario we started with. The manual lists the standard questions for nasal obstruction, like, is it worse in the winter, are you sneezing, things like that.
The standard allergy stuff.
Right. But then it drops the criteria for identifying CSF rhinorrhea, which is the cerebrospinal fluid leaking through a fracture in the base of the skull and dripping out the nose.
The ultimate hidden tripwire.
Exactly. The manual provides 2 mechanical clues to distinguish brain fluid from standard mucus. First, it's not aggravated by bending forward or straining.
Because the pressure dynamics are completely different there.
Right. And the second clue, as we mentioned at the start, is that you cannot sniff it back. Let's break down the mechanics of why that sniff test actually works.
It's all about vacuums and pressure.
Yeah, when you have a standard head cold, your nasal passages and sinuses are actively secreting mucus. When you inhale sharply, when you sniff, you create a localized negative pressure vacuum in that exact cavity.
Which just pulls the mucus backward into your throat.
Right. The cerebrospinal fluid isn't originating in the sinus cavity,
No, it is dripping down from the cranial vault above. It is driven by the steady, continuous hydrostatic pressure of the fluid that suspends your brain.
which is a constant leak.
Exactly. Your localized sniff in the nasal passage simply does not generate enough negative pressure to counteract the constant gravity-fed drip coming from a much higher pressure system.
That is fascinating. So the doctor builds this robust mental suspect list using these mechanical pressure questions and vocabulary checks. But suspicions aren't diagnoses.
No, they need proof.
Right, the doctor has to bridge the gap between what you're describing and what is physically happening inside your head, and that requires physical evidence.
Enter the examination phase. And the manual presents this phase almost like a choreographed performance.
Here's where it gets really interesting, because it reads exactly like a stage script. It actually provides the literal dialogue for formal introduction and consent.
It really leaves nothing to chance.
It says, quote, "Hi, I am Dr. Arfa Joy. With your permission, I'll examine your ears, nose, and throat. Kindly remove your glasses and undo your upper shirt button."
Which establishes an immediate command of the room while maintaining absolute politeness.
Exactly. And then it lays down a strict procedural rule, which is to always examine the good ear before the bad ear.
And that serves 2 vital functions. Practically, you avoid cross-contamination.
Right, you don't want to spread the infection.
Exactly. You do not want to insert a speculum into a severely infected ear and then introduce that same instrument into the patient's healthy ear. But analytically, it provides the doctor with a personalized baseline.
Because everyone's normal is different, right?
Exactly. Normal varies drastically from person to person. By studying the healthy anatomy first, the doctor calibrates their eye to your specific baseline before analyzing the pathology.
That makes so much sense. Then we get into the physical tools. The manual focuses heavily on the speculum for peering inside, and something called the Johnson horn probe.
Right, the probe.
Yeah, which is a thin metal instrument with a small ring on one end used for cleaning out debris. The manual explicitly instructs the medical student to wrap cotton tightly onto the probe before the exam even begins. It specifically states this is so you don't waste time wrapping cotton while holding the speculum.
It is a profound lesson in maintaining the rhythm of the exam and managing patient anxiety.
Is time really that critical though? Or is it just about not looking clumsy?
Well, put yourself in the patient's shoes. You've got a stranger hovering over you, shining a bright light into a highly sensitive, inflamed ear canal.
Yeah, which is already stressful.
Exactly. If they suddenly stop, pull away, fiddle with a metal rod, try to wrap a wisp of cotton around it, and then come back, well, the flow is broken.
I see.
The anticipation of pain often causes more anxiety than the pain itself. The choreography of the physical exam must be seamless so the patient remains relaxed. A flinching patient makes a safe examination nearly impossible.
That is such a human element to this highly clinical manual. Speaking of the sensory experience of the exam, there's an instruction section that caught me completely off guard.
Oh, I think I know which one you're talking about.
Yeah, the manual explicitly tells the examiner, quote, "Don't forget to smell the otoscope or Jobson horn probe to find out whether the discharge is foul-smelling or not."
It's decidedly unglamorous, but diagnostically invaluable.
It's wild to me. Pulling a metal probe out of someone's infected ear and taking a deliberate whiff.
Yeah.
Why is this sense so critical?
Because different families of bacteria produce distinct metabolic byproducts. When you have a standard aerobic infection, bacteria that thrive in oxygen,
Right.
the discharge might look awful, but it generally doesn't have a strong putrid odor. However, anaerobic bacteria, which thrive in oxygen-deprived environments like the deep blocked crevices of the middle ear,
They smell different,
they produce volatile sulfur compounds.
like the smell of decay.
Precisely. A foul smell immediately alerts the physician to an anaerobic infection, or worse, osteomyelitis, which is the infection and necrosis of the surrounding bone.
Oh wow, literal bone decay.
Yes. The presence of that smell changes the entire trajectory of the treatment plan, often requiring aggressive surgical intervention rather than just, some ear drops.
So they are looking for fluid, they're smelling for bone decay, and then they start testing the mechanical function of the ear in real time. They ask the patient to perform Valsalva's maneuver, which is pinching the nose, closing the mouth, and blowing forcefully.
Right, the exact same thing you do to equalize pressure on an airplane.
Right. And while the patient is doing that, the doctor looks through a pneumatic otoscope, which is a specialized light with a magnifying lens that seals the ear canal.
They are watching the tympanic membrane, the eardrum.
Yeah, if the system is working, the forced air from the lungs travels up the eustachian tube and physically pushes the eardrum outward. The doctor literally watches the eardrum bulge to confirm the internal pressure valve is functional.
It's all about pressure equalization. But, up to this point, the manual has treated the ear like an acoustic funnel and a pressure valve. But this is where the exam takes a massive physiological turn.
Yes. This is where we leave the physical structure of the ear and enter the deep neurological wiring. The manual outlines an ear exam, but it includes tests that seem to have absolutely nothing to do with the ear. Let's talk about the tuning forks first.
Okay, yes.
They use them for two specific tests, Rin's test and Weber's test. How does banging a piece of metal on your knee and holding it to a patient's head diagnose hearing loss?
It's all about comparing air conduction to bone conduction.
Okay, walk me through that.
So in Rin's test, the doctor strikes the tuning fork and places the vibrating base directly onto the massoid bone, which is that hard bone right behind your ear.
Right, I can feel that.
This bypasses the ear canal and the eardrum entirely. It sends vibrations directly through the skull to the inner ear's fluid. Then the doctor moves the vibrating prongs in front of the ear canal to test normal air conduction.
And in a healthy ear, air conduction is more efficient, right? So the sound should be louder when it's just held next to the ear.
Exactly. But if the patient says the tuning fork was louder when it was pressed against their skull,
Then the doctor instantly knows there's a mechanical blockage, like fluid, wax, or damaged eardrum, preventing sound waves from traveling through the air.
precisely. The inner nerve is perfectly fine because it heard the vibration through the bone. That is what we call a conductive hearing loss.
And Weber's test verifies this by placing the tuning fork right in the middle of the forehead.
Yes.
If you have a blocked left ear, the sound actually lateralizes, meaning it sounds louder, in the blocked ear,
What?
which seems counterintuitive until you realize the blockage in the left ear is muffling all the ambient room noise.
Right, it's blocking out the room.
Yeah, allowing that inner ear to focus entirely on the pure bone-conducted vibration from the tuning fork on your forehead.
It is literally acoustic physics applied directly to the exam table.
So clever. But the manual pushes even further beyond acoustic physics into movement and balance. They check for nystagmus, which is an involuntary rapid twitching of the eyes.
Yes, the eye twitch.
And they perform cerebellar tests, asking the patient to do rapid alternating hand movements to check for dysdiadochokinesia.
That is a mouthful of a medical term.
Right, dysdiadochokinesia. They also make the patient stand with their feet together and their eyes closed for Romberg's test, or march in place with their eyes closed for Unterberger's test, to see if they sway or rotate.
It seems like a field sobriety test.
It really does. We need to explain why an ear doctor cares if you can flip your hands back and forth quickly or stand perfectly still.
Well, if we connect this to the bigger picture to understand this, we have to redefine what the inner ear actually is. It is not just a microphone. Deep inside the temporal bone, past the eardrum, sits the vestibular system.
Okay.
It consists of 3 semicircular canals filled with a specialized fluid called endolymph.
So it's basically the body's organic gyroscope.
Exactly. When you move your head, that fluid shifts, bending microscopic hair cells that send electrical signals to your brain about your position in 3-dimensional space.
Which is incredible.
And those signals do not operate in a vacuum. They are hardwired directly into the neural pathways that control your eye muscles, and they feed massive amounts of data to the cerebellum, which is the brain's coordination center.
So they're all running on the exact same neurological circuit board.
Yes. If a severe infection, a virus, or a tumor disrupts the fluid in your inner ear, it starts sending garbage data to your brain.
Oh, I see.
Your brain receives a signal that you are spinning, even though your body is sitting still. To compensate for the phantom spin, the brain automatically twitches your eyes. That's the nystagmus.
And when the cerebellum receives that garbage data from the ear, it suddenly can't coordinate rapid muscle movement.
Which is why the patient loses the ability to perform rapid alternating hand movements, the dysdiadochokinesia.
Wow. And that explains the balance test too. When you close your eyes for Romberg's test, you remove your visual anchor to the room.
Exactly. Your brain has to rely entirely on the data from your inner ear and your muscles to keep you upright against gravity. If the inner ear is compromised, the moment you close your eyes, you lose your balance and sway.
That is diagnostic triangulation at its finest. They are testing the deep hardware of the brain and the body's gyroscope without ever having to order a single MRI.
It really is brilliant.
So the doctor has gathered the history, smelled the tools, tested the acoustic physics with a tuning fork, and stressed the inner ear's gyroscope. Now comes the final hurdle. All of this physical, sensory, and neurological data has to be translated into a universal medical language.
Right, the medical record.
The third section of this manual is entirely about decoding the jargon, because a doctor cannot just write, the patient's ear is gross and they feel dizzy.
Obviously not.
They have to translate their findings into standardized terminology so that if you end up in the ER a week later, the next specialist knows exactly what they're looking at.
Standardization removes subjectivity.
Let's look at how they categorize discharge. The manual forces the doctor to place all those visual and tactile details into 4 rigid buckets.
Right.
First, serous, which means the fluid is thin, watery, and colorless. Second, mucoid, thin, but possessing some color. Third, mucopurulent, tenacious, sticky, with significant color. And fourth, purulent, which is pure pus. I'm assuming the difference between labeling something mucoid versus purulent significantly alters what happens next.
Absolutely it does, because watery or sticky means different things to different people, but purulent has a strict medical definition.
Meaning what, exactly?
It indicates a high concentration of dead white blood cells, dead tissue, and active bacteria. A serious discharge might just require observation or like a mild anti-inflammatory. A purulent discharge demands targeted antibiotics and potentially a culture to identify the specific pathogen.
So the stakes are high for getting the word right, and the manual demands that same exactness for the physical structures. When describing a ruptured eardrum, a doctor can't just write hole in the eardrum.
No, they have to be precise.
The template instructs them to map it like coordinates. It says, there is a 30% rounded central perforation in the anterior third of the pars tensa with smooth margins. The pars tensa being the tightly stretched lower portion of the eardrum, essentially the primary vibrating skin of the drum.
It provides the next physician with a topographical map of a piece of tissue smaller than a dime.
They also have to note the presence of tympanosclerotic patches,
Yes.
which are basically chalky white calcium deposits that form as scar tissue on the eardrum after repeated infections, stiffening the drum and reducing its ability to vibrate. But amidst all this hyper-specific mapping, there's an instruction that really caught my attention.
What's that?
The manual places an enormous emphasis on documenting the negatives.
Ah, yes, the pertinent negatives. They are the unsung heroes of medical documentation.
The manual explicitly instructs the doctor to write down symptoms and physical signs that are absent. It gives examples like tracheal tenderness is absent, or nystagmus is absent, and fistula test is negative, or lymph nodes are not palpable. My initial reaction reading this was, why is it so vital to document things that aren't there? Isn't writing no tracheal tenderness just wasting ink if the patient never complained about their outer ear hurting in the first place?
What's fascinating here is you have to think of the medical chart like a pilot's pre-flight checklist.
Okay.
When a pilot inspects the aircraft, they don't just log the mechanical failures. They explicitly log that the flaps are working, the landing gear is functional, and there is no smoke from the engine.
Right, to prove they checked.
Exactly. They do this because because if an incident happens later, the National Transportation Safety Board needs to know the exact baseline of the aircraft before it took off. In medicine, silence in a chart is not golden. Silence is ambiguous.
Oh, that makes perfect sense. If a doctor reads a chart from a previous visit and sees absolutely nothing written about the lymph nodes, they have a date again.
They don't know if the lymph nodes were normal or if the previous doctor was rushed and simply forgot to check them. By documenting a pertinent negative, by writing lymph nodes are not palpable, you are providing proof of the process.
You're leaving a trail.
You are telling the next physician, I recognize the possibility of a systemic infection or lymphoma. I physically palpated the neck and I confirmed that danger was absent. It establishes an undeniable baseline that protects the patient from misdiagnoses and protects the doctor from liability.
Silence is ambiguous. I really like that framing. So the next time you are sitting in a clinic and the doctor is furiously typing on their laptop while you're talking, they aren't ignoring you. They are meticulously logging all the terrifying conditions you don't have.
Exactly right.
Let's take a step back and look at the journey this manual has taken us on. We started with the investigative phase, learning how the difference between a fluctuating and constant symptom completely alters the biological suspect list.
Right, and how the inability to sniff back a runny nose acts as a mechanical red flag for leaking brain fluid.
Then we moved into the physical choreography of the exam room, exploring the necessity of examining the good ear first to establish a baseline.
And of course, the unglamorous reality of smelling medical instruments to detect bone decay.
Which I will never forget. We unpacked the physics of tuning forks, bypassing the middle ear to test bone conduction, and we realized that the ear is actually the body's gyroscope, hardwired into our eyes and our cerebellum.
It's all connected.
And finally, we saw how all of that physical data is translated into a rigid taxonomy of purulent discharges and pertinent negatives to ensure nothing is lost in translation.
It reveals the massive amount of invisible labor and structured thinking that goes into a standard medical checkup.
And for you listening, this changes the dynamic of your next doctor's visit. When you sit on that crinkly paper and your doctor asks you to close your eyes and march in place, or asks if your hearing loss fluctuates, you aren't just a passive participant anymore.
You know exactly what they're looking for.
You understand the hidden mechanisms they are testing. You are an insider to the diagnostic algorithm. But I want to leave you with a final thought to mull over, something that pushes against the boundaries of the source material we've explored today. This clinical guidebook provides a flawless, highly logical script. It assumes a pristine environment. It assumes the patient can articulate the difference between hearing sounds and understanding words.
Which isn't always the case.
Right. What happens to this rigid medical choreography when it collides with a patient who simply doesn't fit the mold?
That's the real challenge.
What happens when the doctor is faced with a patient suffering from dementia who cannot provide a timeline? Or a terrified toddler who is thrashing and won't allow the cotton wrap probe anywhere near their ear? Or someone with a complex web of overlinking contradictory symptoms that blur the lines between mucoid and purulent?
That is exactly where the perfectly structured manual reaches its absolute limits.
And that is the friction point we have to wonder about. How does the intuitive art of medicine take over when the perfect science of the clinical script falls short? Because as much as we want a diagnosis to be a clean binary process, the messy reality of human biology will always find a way to challenge the manual.